Hello, everyone, and welcome to our module on pulmonary hypertension. So pulmonary hypertension refers to an increase in the blood pressure in the pulmonary arteries that deliver blood from the right ventricle to the lungs. And a normal pressure in the pulmonary arteries is about 24/12 with a mean of about 10 to 14. The definition of pulmonary hypertension is a mean pressure greater than 20 millimeters in the pulmonary arteries. And we'll talk about why this is bad in just a minute. One thing to be aware of, especially for board exams, is that there is a clinical finding when you examine patients with pulmonary hypertension, and that is a loud P2. So P2 is the pulmonary component of the second heart sound, and it is accentuated or loud in patients who have pulmonary hypertension. This is a heart sound heard best at the left upper sternal border, and especially in board questions, they may describe a loud P2 or a loud second heart sound, and they're trying to tell you that the patient has pulmonary hypertension. The main clinical symptom that patients report when they have pulmonary hypertension is dyspnea, meaning shortness of breath, especially with exertion, sometimes together with hypoxemia. The reason this happens when the blood pressure gets high in the pulmonary arteries is multifactorial, and I think they're unlikely to ask you about this on board exams because it's so complex. But different studies have looked at this, and they've found evidence of VQ mismatch in pulmonary hypertension, also reduced DLCO and intrapulmonary shunting. And so all these mechanisms sort of conspire to cause the dyspnea and hypoxemia associated with pulmonary hypertension. Besides the symptoms of dyspnea and hypoxemia, the reason that pulmonary hypertension is bad is because it can cause the right ventricle to fail. So when the pressure in the pulmonary arteries is high, that means the right ventricle has to generate a higher pressure to drive blood flow into the pulmonary arteries. Over time, this will initially lead to hypertrophy of the right ventricle. And when patients have right ventricular hypertrophy, they can get a sign on physical exam that you can appreciate. It's called a parasternal heave. This is a visible heave of the chest over the right ventricle. And anytime you see this, it indicates an overactive right ventricle. Now, initially, what you get from pulmonary hypertension is right ventricular hypertrophy, but over time, it can lead to a clinical syndrome known as cor pulmonale. This is what happens when there's chronic high pressure inside the right ventricle. The right ventricle will eventually dilate and fail because of the high blood pressure, and this can lead to all the clinical findings of right heart failure, things like jugular venous distension, lower extremity edema, the liver can become congested and there can be hepatomegaly, and eventually the way that people die from pulmonary hypertension is from right heart failure or arrhythmias related to the dilated abnormal right ventricle. Let's talk about how you make the diagnosis of pulmonary hypertension. So the gold standard technique is a right heart catheterization. This involves inserting a catheter into one of the veins, usually in the arm or the leg, and threading it into the pulmonary artery so you can directly measure the pulmonary artery pressure. This is only done in special circumstances, however, because it's an invasive procedure. The way we more often make the diagnosis is non-invasively by echocardiography. So echocardiography involves using ultrasound to take an image of the heart. There are techniques that can measure the velocity of blood flow in the pulmonary arteries, and these can be used in echocardiography to estimate the pulmonary artery pressure and diagnose pulmonary hypertension. You can also visualize the right heart structures by echocardiography, just like you're seeing the right ventricle here, and that can be helpful as well to let you know if the right ventricle is dilated or failing. When you examine the lungs from patients who die of pulmonary hypertension, shown on this slide are some of the pathology findings that you can see. So first of all, in the pulmonary artery and its branches, you can see arteriosclerosis, which means thickening of the arterial walls. You can also see proliferation of smooth muscle cells. This is a picture of what it can look like here. You have thickening of the medial layer of the pulmonary arteries, and this narrows the lumen. And that's what you can see in this picture right here, thickening of the medial layer with a very narrow lumen compared to normal. Okay, now we're going to talk about all the different causes of pulmonary hypertension, and there are a lot of these, but the way I've always kept them straight in my mind is by remembering the flow equation, which is what I've shown on the slide here. I talk about the flow equation in detail in videos in the cardiology section, but according to this equation, the pressure in the pulmonary arteries is going to be equal to the cardiac output times the pulmonary vascular resistance plus the pressure in the left atrium. To understand what the flow equation is telling us, let's imagine we have the lungs and we have blood flowing into the lungs with a pressure of the pulmonary artery pressure. Blood then leaves the lungs and goes out into the pulmonary veins and the left atrium, so the pressure on the other side of the lungs is going to be the left atrial pressure. Well, if you think about what can make this pulmonary artery pressure high, one thing that's fairly easy to understand is a high left atrial pressure. If this pressure goes up, then you're going to need more pressure in the pulmonary arteries in order to drive flow in this direction through the lungs. But if the left atrial pressure is normal, the other way you can get a high pulmonary artery pressure is if there's lots of resistance to flow through the lungs. That will cause the pressure back here to go up, and that is another thing that can give you high pulmonary artery pressure. So that's basically what this flow equation is telling us, that the pressure in the pulmonary arteries can go up if you have a rise in the pulmonary vascular resistance or a rise in the left atrial pressure. So what are some things that can give us a rise in the left atrial pressure? Well, that's anything that causes the left heart to fail. So heart failure, valve disease, all these things can raise the pressure in the left atrium. And it turns out this is the most common cause of pulmonary hypertension. We call this pulmonary venous hypertension because the pressure is high in the pulmonary veins, which are connected to the left atrium. The other way you can get pulmonary hypertension is if you have a high pulmonary vascular resistance. When this happens, we call it pulmonary arterial hypertension because the pressure is high in the pulmonary arteries, but not in the pulmonary veins, which are beyond the lungs. And there are primary and secondary forms of pulmonary arterial hypertension, and we're going to talk about those in just a minute. So to understand why high left atrial pressure can cause pulmonary hypertension, let's take a look at this little diagram I've made here. So we have blood flowing in through the pulmonary arteries to the lungs at a normal mean pressure of 14. It goes into capillaries that are near the alveoli. It picks up oxygen, it releases carbon dioxide, and then the blood flows out into the pulmonary veins where the pressure is about 5 millimeters of mercury, which is a normal left atrial pressure. Well, now let's imagine that the patient develops heart failure, and so instead of 5 millimeters of mercury, this pressure goes up to 20. Well, that means the pressure over here is going to have to go up in order to continue to drive blood flow. This might have to be something like 30 or even 40. And so this is how high pressure in the left atrium causes pulmonary venous hypertension, which in turn causes pulmonary arterial hypertension. So I can't emphasize this enough, but so-called left heart disease, which means problems with the left ventricle and the valves of the left ventricle, are the most common cause of pulmonary hypertension. These things cause pulmonary venous hypertension, and basically any cause of high left atrial pressure can lead to pulmonary hypertension through this mechanism. So heart failure can do this, mitral stenosis, mitral regurgitation, any problem on the left side of the heart that raises the left atrial pressure. The other way to get high pulmonary artery pressure, as we said, is to have high pulmonary vascular resistance. This is called pulmonary arterial hypertension because you only have high pressure in the pulmonary arteries, not the pulmonary veins. So one thing that can raise the PVR causing pulmonary hypertension is chronic lung disease. Patients with chronic lung disease have chronic hypoxemia, and pulmonary vessels vasoconstrict in the setting of hypoxemia. So many patients with COPD or other chronic lung disease develop pulmonary hypertension through this mechanism. You can also see pulmonary hypertension from high PVR in patients who have sleep apnea or patients who are at high altitude exposed to chronic hypoxia. Anything basically that causes chronic hypoxemia is going to lead to vasoconstriction and a rise in the PVR, leading to pulmonary hypertension. Another way you can have high pulmonary vascular resistance is if a patient has chronic pulmonary emboli. Sometimes this happens. Patients are chronically delivering blood clots to small branches of the pulmonary arteries. This takes away the area for blood flow and causes there to be higher pulmonary vascular resistance. And so this is another way you can get pulmonary hypertension through high pulmonary vascular resistance. So the World Health Organization classifies pulmonary hypertension into 5 distinct groups. And if you understand everything we went through in the last couple of slides, these groups are fairly straightforward to understand. So the group 2 patients, let's talk about them first. These are patients who have pulmonary hypertension due to left heart disease, meaning high left atrial pressure, just like we discussed. The group 3 patients are patients who have pulmonary hypertension due to chronic lung disease or hypoxemia. So these are patients with COPD or interstitial lung disease or some reason for hypoxemic vasoconstriction like sleep apnea or high altitude exposure. The group 4 patients are patients who have pulmonary hypertension due to pulmonary artery obstructions like chronic PE, as we just discussed. And then there are a number of patients who have a high PVR, but they don't have chronic lung disease. We're going to talk about these patients in a minute, but these patients are called group 1 pulmonary hypertension patients. They have a high PVR, not due to chronic lung disease like these things here. And then finally, group 5 is sort of a catch-all group for rare patients who have pulmonary hypertension due to unclear or multifactorial mechanisms. And I won't talk much about this group. It's sort of a special group that you can read about if you wish. So just to emphasize this point, pulmonary arterial hypertension refers to pulmonary hypertension due to high pulmonary vascular resistance. It's called pulmonary arterial hypertension because you have high pressure in the pulmonary arteries but not the pulmonary veins. And the WHO breaks down patients with pulmonary arterial hypertension into three groups. The group 1 patients have no chronic lung disease, group 3 patients have chronic lung disease, and group 4 patients have chronic embolic disease. So now let's talk about those group 1 pulmonary arterial hypertension patients. These patients have high pulmonary vascular resistance with no associated lung disease. Sometimes this occurs in isolation. This is idiopathic group 1 PAH, and we'll talk about this in a minute. But many times it occurs in association with certain other disorders. So for example, patients who have connective tissue disease, especially scleroderma, commonly become group 1 pulmonary arterial hypertension patients. You can also see this type of pulmonary hypertension in patients who have HIV. Untreated congenital heart disease can eventually lead to Eisenmenger syndrome, which I talk about in other videos. That leads to the development of group 1 PAH. Schistosomiasis, which is chronic infection of the lungs by a parasite, that can lead to group 1 PAH. And then finally, patients who chronically use certain drugs like amphetamines or cocaine can also develop this group 1 type pulmonary arterial hypertension. So let's talk about the idiopathic pulmonary arterial hypertension patients. This is a rare disease that classically affects young women, and for reasons that are unclear, they develop high pulmonary vascular resistance in the absence of chronic lung disease, or one of those other associated conditions we talked about in the last slide. The basic science literature on this has shown that many of these patients have an increased activity of certain pulmonary vasoconstrictors, especially endothelin, and a decreased activity of certain pulmonary vasodilators like nitric oxide. And so these types of things sort of conspire to cause this idiopathic form of pulmonary arterial hypertension. Let's talk about plexiform lesions. So these are a pathfinding that's unique to idiopathic pulmonary arterial hypertension. Plexiform lesions are caused by significant endothelial proliferation to the point that the blood vessel develops multiple lumens. So this is a nice picture over here on the left side. You can see that there's so much proliferation of cells that you're developing multiple lumens. It almost looks like there are 2 lumens here. And that's a plexiform lesion, a unique pathfinding in idiopathic pulmonary arterial hypertension. There are hereditary forms of pulmonary arterial hypertension that run in families. Some of these have been tied to BMPR2, which is bone morphogenic protein receptor type 2. It's a protein that inhibits smooth muscle proliferation. And so when there's a mutation of the gene that codes for this, that leads to lack of inhibition of smooth muscle proliferation. So you get abnormal growth of the endothelium and smooth muscle, and this can narrow the lumens of pulmonary vessels, and that can lead to hereditary PAH. You find mutations of this gene in about 25% of idiopathic PAH cases, but up to 80% of familial cases, and that's why this gene is tied to hereditary PAH. Now I'm going to talk about pulmonary arterial hypertension treatments, and the common theme to all these treatments is that they all lower the pulmonary vascular resistance. So these are treatments that are used mostly in group 1 patients who have high PVR. You wouldn't use any of these treatments in a group 2 patient who has high left atrial pressure. Those patients need treatment for their left heart failure. So the first group of treatments for PAH are the prostacyclin synthetic analogs. These are IV drugs. These are the names of some of them here. Epoprostenol was one of the first ones to come out, but others have entered the market. So prostacyclin is also called prostaglandin I2, and it's a potent vasodilator. And so all these drugs are analogs that work just like prostacyclin, and they cause dilation of pulmonary blood vessels. Problem with these drugs is that they're IV, and so it can be difficult for patients to take. So decades ago, the prostacyclin analogs were the only drugs available to treat PAH, and these were difficult for patients because they required a chronic infusion. Now, however, there are a bunch of new classes of drugs. They're shown on this slide, and many of these are oral drugs, and this has made it much easier to treat PAH. So the first group are the antagonists to the endothelin-1 receptors. These are oral drugs. The classic drug is bosentan, but some others have come along as well. Another group are inhibitors of PDE5 in lung smooth muscle. So these drugs work through the same mechanism that drugs used to treat erectile dysfunction work. They are drugs like sildenafil, which is used to treat erectile dysfunction, but it can also be used to treat PAH. And then lastly, there are so-called soluble guanate cyclase stimulators. These are drugs that relax the pulmonary arteries and cause vasodilation. The major drug in this class is riociguat. And this diagram I've placed on the slide here shows all the different pathways that affect the pulmonary vessels and where the drugs work. I think it's kind of busy and hard to follow. Mostly what you just want to remember are these mechanisms here. These drugs aren't super high yield for your step exams, but you may get 1 or 2 questions about them, so you just want to know how they work. And that concludes our module on pulmonary hypertension.